you're a Black patient with Crohn's, the data says your gastroenterologist is statistically less likely to offer you a biologic, and that's not a conspiracy theory. It's published research. Hi, I'm Kate, and today we're talking about a disparity in Crohn's care that doesn't get nearly enough airtime, and what you can actually do about it. Because information is only useful if it leads somewhere, and today it's going to. When my husband was going through his 3 surgeries, I used to sit in the waiting rooms and wonder, is he getting everything available to him? Is someone looking at the full picture? That fear that the system might be missing something or not trying hard enough, that's a fear a lot of Crohn's family carry. But for Black patients and their families, that fear isn't just anxiety, it's actually backed up by data. I work at the intersection of integrative and conventional care. That means I talk to a lot of patients who've fallen through gaps, people who were told to manage stress when they needed a scope, people who waited years for a diagnosis that should have come sooner, and I see over and over again that those gaps are not randomly distributed. Black patients with Crohn's are diagnosed later. They're less likely to receive biologic therapy and they reach surgery at higher rates. If you're living this, if you're a Black patient or you're caring for one, I want you to know this. This is real, it's documented, and you're not imagining it. And I want to give you something useful today, not just the problem, but the path through it. Here's what most people assume when they hear about a disparity like this. They assume it must come down to one bad actor, one biased doctor, one discriminatory insurer. And then they think, well, that's not my doctor, so it probably doesn't apply to me. Well, that's not how structural disparity works. The research, and there's a growing body of it, published in journals like Gastroenterology and Inflammatory Bowel Diseases, shows that Black patients with Crohn's are underrepresented in biologic prescribing even after you control for disease severity. That means it's not just that Black patients present differently or have milder disease. The gap persists when you look at patients with comparable disease activity. So what's actually driving it? It's not usually one villain, it's a system of smaller frictions that compound. Referral delays, implicit bias in how pain and symptoms get assessed and believed, insurance gatekeeping that's harder to navigate without the right advocacy, and a clinical pipeline where, if you don't get escalated early, you don't get to the specialist who prescribes biologics in the first place. The real issue isn't that medicine is full of people who consciously want to give Black patients worse care. The real issue is a system that produces worse outcomes for Black patients without anyone necessarily intending it, and that keeps producing those outcomes unless someone actively interrupts the pattern. That someone, well, it might have to be you. So let's talk about what you can actually do. I'm going to give you 5 specific things, whether you're the patient, the carer, or someone who just wants to understand this a little better. So you need to know what biologics are and why they matter in Crohn's. That's the first step. Well, biologics are a class of medications, things like infliximab, etc. They target specific parts of the immune response driving inflammation in Crohn's. They're not a first step for every patient, but for moderate to severe disease, the research is clear. Early use of biologics is associated with better long-term outcomes, including lower rates of surgery and hospitalization. The reason this matters is this. If you don't know biologics exist, or if no one has ever mentioned them to you, you can't ask about them. Knowledge is the first door, and right now I want to make sure that that door is open. Okay, second, understand the referral pathway and where the gaps are. In most healthcare symptoms, the path to a biologic goes through a gastroenterologist, often one who specializes in IBD. The problem is that Black patients are less likely to be referred to a specialist early and less likely to be referred to a dedicated IBD clinic specifically. General gastroenterology and IBD specialist gastroenterology, well, they're not the same thing. An IBD specialist is more likely to be up to date on biologic options, more likely to have access to clinical trials, and more likely to escalate treatment proactively. So the question to ask your current doctor is this, and it's direct. Am I being seen by someone who specializes in IBD? And if not, can I get a referral to an IBD specialist or a dedicated IBD center? It's not a confrontational question. That's a reasonable, informed question, and any good doctor should be able to answer it or act on it. Okay, number 3, name your symptoms clearly and completely, and please do not minimize them. One of the documented contributors to this disparity is different system assessment, which is a clinical way of saying that Black patients' pain and symptoms are sometimes rated as less severe than they actually are. This has been shown in multiple areas of medicine, not just gastroenterology. You cannot fully control how someone else interprets what you say, but you can be as specific and complete as possible. Don't soften your language to be polite. If you're in pain, say you're in pain. If your symptoms are affecting your ability to work, sleep, or leave the house, well then say that out loud. Use a symptom diary. Write down frequency, severity on a scale of 1 to 10, and functional impact, meaning what you can't do because of it, and bring it to your appointment. Numbers and patterns are harder to dismiss than general descriptions. And if you feel like your symptoms aren't being taken seriously, you're allowed to say, I don't feel like the severity of what I'm experiencing is being fully heard. Can we talk about it? 4th, ask specifically about biologics and about the criteria being used. There are clinical guidelines from organisations like ECO in Europe and the ACG in the US that outline when biologic therapy should be considered. You can look these up. They're publicly available. If you have moderate to severe Crohn's, or if you've had an adequate response to other treatments like steroids, biologics should be at minimum on the table as a conversation. The question to ask is, based on my disease activity and my treatment history, am I a candidate for biologic therapy? And if not, what criteria would I need to meet? Now that second part matters, because if there's a clear answer, we'd consider it if X happens, then you know what you're working toward. And if the answer is vague or dismissive, well, that's information too. You can also ask, is there anything about my insurance or my referral pathway that's creating a barrier here? Sometimes the obstacle is administrative, and naming it out loud can move things. 5, build your support structure and bring someone with you. This is practical and it matters. Having an advocate in the room, a partner, a parent, a friend, changes the dynamic of a medical appointment. Someone who can take notes, ask follow-up questions, and help you remember what was said. If you're a carer for someone with Crohn's, this is one of the most concrete things you can do. Be in the room, be informed, ask questions. Not to be adversarial, but because 2 people advocating for the same outcome is more effective than one. And if you're part of a community, a Crohn's support group, an online forum, a patient advocacy network, connect with others who look like you and who've navigated this system. Shared knowledge about which specialists are responsive, which centres have good outcomes, which questions gets results, that's genuinely valuable. Don't underestimate it. I can't, just say how much that advocating for someone is. I know there's been times when my husband's been in hospital after surgery, and I'm pretty sure that if I hadn't have been there at the right time, well then who knows what could have happened. So I think about that a lot, and I wonder about what questions we didn't know to ask and what options we didn't know existed. And so that's why I really want you guys to be on top of this, and if there's someone that you're caring for, really advocate for that person. So with my husband, we were lucky in some ways, but luck shouldn't be the variable that determines whether someone gets the right care. And for too many Black patients with Crohn's, the symptom is producing worse outcomes, not because of bad luck, but because of structural patterns that can be interrupted. If you follow what I've laid out today, if you know your options, ask the right questions, advocate clearly for escalation, and bring someone into that room with you, you are actively working against a pattern that the research says is real. You're not guaranteed a particular outcome. Nobody can promise you that. But you are more likely to be seen, more likely to be heard, and more likely to access the full range of what's available to you. It's worth doing for yourself or for someone you love. If this video helped you, or if you know someone who needs to hear it, please share it. This is the kind of information that should be reaching people before they're in crisis, not after. Now, if you want support navigating Crohn's care, whether you're the patient or the carer, come and find me. I work with families through the Crohn's method and this kind of advocacy work. Knowing what to ask and how to ask it is exactly what we do together. I'll see you in the next video and have a beautiful day.